So we're going to talk about disorders of cardiac function, and we're going to start off by watching a couple of videos. These videos are excellent in helping you understand the pathogenesis of CAD and angina and myocardial infarctions. The first one is a very short video.
The heart is fed by its own circulation, known as the major coronary arteries. These arteries include the left anterior descending artery, the left circumflex coronary artery, and the right coronary artery. The bloodstream contains red blood cells, which deliver oxygen to the heart muscle, known as the myocardium. It also contains fats or lipids, known as low-density lipoproteins, or LDL cholesterol. Atherosclerosis begins when LDL cholesterol accumulates in the arterial wall, forming a plaque. Over time, the plaque becomes larger. Some plaques never obstruct the coronary blood flow. The patient with asymptomatic coronary disease has no chest pain and no myocardial ischemia. A plaque can enlarge to the point that the blood flow is compromised. The patient may have chest pain, but only with exertion. This syndrome is known as stable angina and is not a clinical emergency. Such a patient is still at risk for an acute life-threatening event because a plaque can suddenly rupture, causing clotting of the artery, known as coronary thrombosis. When a thrombotic occlusion is subtotal, an acute coronary syndrome develops, and there are two types. The first type is known as a non-ST segment elevation myocardial infarction, and the second type is known as unstable angina. With these syndromes, the patient experiences chest pain at rest, and the electrocardiogram shows ST segment depression. In contrast, when the thrombus completely occludes the vessel, the myocardium is injured, and the syndrome of ST segment elevation myocardial infarction develops. In summary, patients with coronary artery disease may be asymptomatic, they can have stable angina, or they can suffer an acute atherothrombotic event. Plaque rupture with coronary thrombosis is the most common cause of acute, life-threatening coronary artery disease. Emergency therapy by thrombolysis, angioplasty, or thrombectomy.
So we know that the most common reason heart attacks happen is because of atherosclerotic plaque buildup that happens in your coronary arteries. And this plaque buildup will compromise blood flow to your heart muscle. And when your heart muscle doesn't get access to blood flow, it doesn't get access to oxygen inside that blood. So that's essentially how you get a heart attack. And remember, in medicine, we call heart attacks myocardial infarcts. So myocardial referring to muscle of the heart, and infarct referring to lack of oxygen causing death of tissue. So myocardial infarct, lack of oxygen to heart muscle causing death of that heart muscle. That's what a heart attack is. So we know how a heart attack occurs, but what exactly is happening in your body? What's happening with your heart when you're actually having a heart attack? Well, let's take a look at that. And let's actually start from the beginning here. So let's bring in an artery here, so we can visualize what happens to the heart muscle cells during a heart attack. So here's our artery, and let's draw in our cells now. So there's some heart muscle cells, and so you might have noticed that I drew these cardiomyocytes in a really oddly connected way. So you can see a connection there, and you can see a connection there, and there's one there, and so on. And the reason that cardiomyocytes, that heart muscle cells, are connected in this way is because by being connected like this, they can more efficiently work together to make sure that the heart pumps properly. So what exactly is happening in a heart attack? So let's say we're looking at this blockage right here. And then let's say that the piece of artery that we've drawn is this piece of artery right here. So all of these cardiomyocytes here, all these cardiomyocytes are what's surrounding this vessel here, all right? So it's this piece right here that we're representing. So you got this plaque in your artery upstream, and it's not ruptured, it's just sitting there. It's not really doing too much right now. But then let's say you start playing soccer, right? So you start running around chasing after the ball, and when you're running around, blood is being forced to sort of flow faster and faster through your coronary arteries, right? Because your heart's pumping faster. Well, all that blood sort of rushing through your coronary arteries because your heart's pumping faster, that rushing blood will sort of bombard your plaque, and your plaque might rupture. So let's say it does rupture in this case, and you develop this thrombus. So you develop this big clot on that ruptured plaque. Well, in this case, what do you think is going to happen to the downstream part of that artery? It's not going to get that much blood, right? Because this thrombus is blocking off the blood flow. So whereas before, you had lots of blood flowing through your coronary artery, and therefore your cardiomyocytes were getting lots of oxygen out of that blood. Now, because of that huge clot that's in the way, there's way less blood flow in that coronary artery, right? Blood flow to that heart muscle there starts to slow down. So now all of a sudden, these heart muscle cells aren't really getting all the oxygen they need, right? So now they start to become oxygen starved. They start to get really hungry for oxygen. And when they get really hungry for oxygen, they start to send pain signals to the brain. And these pain signals are basically telling the brain, we've got like no oxygen down here. You need to do something about this now. And actually, this pain can feel a bit like indigestion because you're not really used to pain like this. So your brain kind of gets confused and thinks it's maybe an indigestion pain. So you might actually feel the pain just below your heart, right above your stomach. So this is actually the start of a heart attack. So let's look at our clot now. Well, it's actually still growing, and it's now blocking like 2/3 of the artery. So your pain will start to get worse. And some people might start to get pain in their arms, and mostly we see it in the left arm. And the reason you can get pain in your arms in the first place with a heart attack is because some of the nerves that are connected to the heart have the same origin as some of the ones that are connected to your arm. So since your brain really isn't used to feeling pain from your heart, it sort of gets confused when it does get signals from your heart. And in that confusion, it thinks the pain is coming from your arms. And that's called referred pain. So it's kind of a similar mechanism to the indigestion feeling. And by the same referred pain mechanism, some people even get pain radiating up to their jaw. And so at this point, the brain is confused, right? I mean, it's overloaded with these increasing pain signals coming from the heart, right? And to add to that, you got all of these cardiomyocytes that are running low on oxygen. And because they're running low on oxygen, the nice, normal, coordinated way that your heart beats will be compromised. And your brain doesn't like this. So your brain senses this and says, holy crap, I need to do something about this. So your brain triggers this big surge of adrenaline release into your bloodstream. And the adrenaline gets everywhere. So it gets to your heart and it starts affecting your heart, right? And what does adrenaline do? Adrenaline will start to make your heart beat faster. Your heart will start to race. Unfortunately, the adrenaline's not going to be able to do anything about the clot that's built up, which is actually just growing, right? I mean, we've sort of left it alone for a while, but it's actually getting bigger. And by now, it's filling up basically the whole artery. It's completely blocking the artery off. So now our cardiomyocytes are in big trouble because now they're barely getting any blood, so they're barely going to get any oxygen. And because they're barely getting any oxygen, they necessarily have to slow down their rate of contraction because having good access to oxygen is really key for cardiomyocytes to produce the energy they need to do all the work they have to do. So naturally, if they don't have that oxygen, they can't produce all the energy they need. So they have to slow down. So they start to slow down. And then they start to stop beating altogether. So because our patch of cardiomyocytes here have stopped beating, well, the rest of the heart has to compensate. So the rest of the heart starts beating faster to compensate for our dying patch of cardiomyocytes. Now, at this point, things are not looking good for our cardiomyocytes. They actually can't even hold themselves together in one piece anymore. Their membranes actually start to break down and the cells start to rupture. See, cells without oxygen, without blood supply, they don't get the luxury of having blood carry away their toxic waste products that sort of naturally crop up as part of their regular metabolism. So these toxic waste products start to build up inside of our myocytes, and their membranes start to rupture. And when our cardiomyocytes start to rupture, they start to leak proteins that only heart muscle cells contain. They start to leak these proteins into the bloodstream. These proteins are called troponins. Troponins are a type of structural protein that you only find in heart muscle cells. And so keep that in mind because that'll become important later on. when we talk about diagnosing heart attacks. So now our injured heart is really starting to wear itself out. The beat is starting to get a bit weaker, and you're starting to get even more effects all over your body. For example, it'll start to become really difficult to breathe because you can actually get some fluid buildup in your lungs. And let me just quickly show you how this happens. So here's your heart and here are your lungs. Now remember, blood goes out from your heart to your lungs to get oxygenated. And then once it gets oxygenated, it sort of comes back to your heart, right? And then it gets pumped out of your heart to the rest of your body. Well, when your heart isn't pumping very well, blood will sort of build up in your heart and then back up into the lungs. And this buildup, this backflow of blood can end up making it really difficult for you to breathe. So you'll often get dyspnea, you'll often get shortness of breath when you're having a heart attack. So you've had your referred pain, you're getting your shortness of breath, your heart is racing. Well, because your heart is not pumping efficiently, not enough blood might be getting to your brain, so you could start to get dizzy and disoriented. So by now it's been about 15 to 18 minutes since you started having your heart attack, and now things are getting really, really bad. Your starving heart muscle cells will actually begin to burst and die. They'll actually begin to escalate from just leaking to actually dying. So I'll draw in some dead faces here. But you know, this is really serious. If you're not treated within about 20 minutes, your heart will get damaged so badly that it won't ever beat normally again. Because at this rate, about 20 minutes after your heart attack comes on, you're losing about 500 cardiomyocytes, 500 heart muscle cells per second, And they're not like your average skin cell or your hair, your strand of hair. They can't actually be replaced. So once you lose these cardiomyocytes, that's it. Your heart will not beat normally again. So you really want to limit the amount of cardiomyocyte loss that happens. So that's sort of the physiology behind what's happening in a myocardial infarct. So before we finish up, there's just one more thing I want to show you. So we classify myocardial infarcts into two main groups, and I'll show you those groups. I'll show you how we divide them up. So what I'm going to do to show you this is we're going to take a cross section here across the heart muscle, okay? So I'll draw that cross section. So this is a cross section of the heart. So it's sort of as if we cut away this part on the bottom here and we're looking upward at the heart. That's a little eye there. And so this is the right ventricle on this side. That's the chamber of the right ventricle. And this on this side is the chamber of the left ventricle, right? Because the left ventricle is here and the right ventricle is over there. Now let's draw in our blood vessel. So let's say that right here, right, I'll draw a circle because remember we're cutting the left anterior descending artery, this one here, we're cutting that in cross section as well. Left anterior descending artery. So let's say we block off this left anterior descending. Let's say that we've had a heart attack involving that artery. Well, because it serves such a huge part of the heart wall, what's going to happen is we're going to knock off a big part of the heart wall. We're going to knock off a huge chunk of it, right? And so this type of infarct is called a full thickness infarct because it involves the entire thickness of the thick muscular wall of the heart. So that's called a full thickness infarct or a transmural infarct. And transmural, by the way, just means mural refers to wall and trans just means sort of crossing. So transmural means it's just crossing the entire wall. That's how big the infarct is, transmural. So that's one type of heart attack. That's one type. And the second kind, let's put it up here, the second kind is called a partial thickness infarct, or a subendocardial. That's the other word for it, subendocardial infarct. Well, how does that happen? Well, that happens because you'll have these little arteries that come off of the big ones. So, for example, there'll be this little one that comes off of the left anterior descending, and it will actually penetrate through the heart muscle wall, right? Because the goal of this artery is to supply blood to this little patch here. Okay, so let's say that the supply zone, the oxygen supply zone, the blood supply zone for this little penetrating artery is this area here. Well, let's say that you get a clot that develops in this artery here. Then you'll still have a heart attack. You'll still have a myocardial infarct, but it'll be one of a much smaller region, right? It won't actually be a full thickness. It won't be a full thickness infarct. It'll just be a partial thickness. So those are the two major types of myocardial infarcts.
Okay, one more video I want you to watch, and only because I think that these three videos together cover generally almost all of the information that are on the slides. So as you're watching those videos, you should be able to answer or at least have a good note taking for the slides that you have in front of you on your PowerPoint. And this is the last video of this section.
According to the World Health Organization, cardiovascular disease is the leading cause of death worldwide, as well as in the US. Of those, a large proportion are caused by heart attacks, also known as acute myocardial infarctions or just myocardial infarctions, sometimes just called MIs. The word infarction means that some area of tissue has died due to a lack of blood flow, and therefore a lack of oxygen. Myo refers to the muscle, and cardial refers to the heart tissue. So with a heart attack, or MI, you have a death of heart muscle cells because of a lack in blood flow, a process called necrosis. Now, the heart's main job is to pump blood to your body's tissues, right? Well, the heart also needs blood, and so it also pumps blood to itself, using the coronary circulation. The coronary circulation is the system of small arteries and veins that help keep the heart cells supplied with fresh oxygen. Heart attacks happen when these small arteries become blocked and stop supplying blood to the heart tissue. And if this happens for long enough, heart tissue dies. Almost all heart attacks are ultimately a result of endothelial cell dysfunction, which relates to anything that irritates or inflames the slippery inner lining of the artery, the tunica intima. One classic irritant are the toxins found in tobacco, which float around in the blood and damage these cells. That damage then becomes a site for atherosclerosis, a type of coronary artery disease where deposits of fat, cholesterol, proteins, calcium, and white blood cells build up and start to block blood flow to the heart tissue. This mound of stuff has two parts to it: the soft, cheesy textured interior and the hard outer shell, which is called the fibrous cap. Collectively, this whole thing's ominously called plaque. Usually, though, it takes years for plaque to build up, and this slow blockage only partially blocks the coronary arteries. And so, even though less blood makes it to the heart tissue, there's still blood. Heart attacks happen when there's a sudden, complete blockage or occlusion of a coronary artery. So let's see how that can happen. Since these plaques sit right in the lumen of the blood vessel, they're constantly being stressed by mechanical forces from blood flow. And interestingly, it's often the smaller plaques with softer caps rather than the larger ones with harder caps that are especially prone to break or get ripped off. Once that happens, the inner cheesy filling, which remember is this mix of fat, cholesterol, proteins, calcium, and white blood cells, is thrombogenic. And this means that it tends to form clots very quickly. So platelets, or blood clotting components in the blood, flow by and get excited, and they adhere to this exposed cheesy material. In addition to piling up, the platelets also release chemicals that enhance the clotting process. Now this happens super fast. Think about how quickly a small cut stops bleeding. That's a very similar process. It happens in a matter of minutes, right? And now that coronary artery is fully occluded. So now let's change views a bit. If we take a slice of the heart like this side being posterior or the back, and this being anterior or the front, with the left and the right ventricles here, and then we have the three most commonly blocked arteries: the left anterior descending, or LAD, which supplies blood to the anterior wall and septum of the left ventricle, which accounts for about 40 to 50% of cases; the right coronary artery, or the RCA, which covers the posterior wall, septum, and papillary muscles of the left ventricle, accounts for about 30 to 40% of cases; and finally the left circumflex artery, or the LCX, which supplies the lateral wall of the left ventricle, about 15 to 20% of cases. Notice that the majority of these areas supply the left ventricle. Most heart attacks therefore involve the left ventricle, where the right ventricle and both atria, the upper chambers, aren't as often affected. Each of these areas is called the artery's zone of perfusion, and if we take a closer look at one of these zones, we'll see that basically you've got the endocardium, which is the smooth membrane on the inside of the heart, and then the myocardium, all the heart muscle, and then the epicardium, the outer surface of the heart, which is where the coronary arteries live. Let's say the LAD gets blocked. The area of perfusion is now at serious risk, and within about a minute, the muscle cells in this zone don't see enough oxygen and become ischemic, and the muscle layer's ability to contract is severely reduced. This initial stage is extremely sensitive, since the ischemic damage to cells in the perfusion zone is potentially reversible. After about 20 to 40 minutes, though, damage starts to become irreversible and the cells start to die. And this zone changes to a zone of necrosis, or dead tissue. Once lost, those cells can never return or regrow. That's why quickly identifying and treating an MI is super important. The first area affected is the inner third of the myocardium, since it's the farthest from the coronary artery and the last area to receive blood, and it's subject to higher pressures from the inside of the heart. If the blockage suddenly lyses or breaks down and blood flow returns, sometimes patients' damage will be limited to the inner third, and this would be called a subendocardial infarct. An ECG, or electrocardiogram, done at this point typically shows an ST segment depression, or in other words, it doesn't show ST segment elevation. So sometimes we call this an NSTEMI, which stands for non-ST elevation myocardial infarction. Other causes of this sort of subendocardial infarct would be severe atherosclerosis and hypotension, anything that ultimately leads to poor perfusion of the heart tissue. After about 3 to 6 hours, though, the zone of necrosis extends through the entire wall thickness, called the transmural infarct, which this time shows up as ST segment elevation on ECG, which is why they're sometimes called STEMIs, or ST elevation myocardial infarctions. So the difference between NSTEMIs and STEMIs is that NSTEMIs don't have ST segment elevation, and these are caused by partial infarct of the wall, whereas STEMIs have ST segment elevation and involve the whole wall thickness. Patients that have an MI will most commonly have severe and crushing chest pain or pressure that might radiate up to the left arm or jaw. They might have diaphoresis or sweating, nausea, fatigue, and dyspnea. All of these are either a direct result of an end organ, like the heart or the brain not getting enough perfusion, so think chest pain and dizziness, or from the sympathetic response from the body to help the heart work harder and preserve blood pressure, so think sweating and clammy skin. Many people also have referred pain, where the nerves in the heart are irritated, but that pain can be felt in the jaw, shoulder, arm, or back instead. In addition to an ECG, labs can be very useful in diagnosing an MI. When there's been irreversible damage to heart cells, their membranes become damaged and the proteins and enzymes inside escape and can enter the bloodstream. 3 key ones are troponin I, troponin T, and CKMB, which is a combination of creatine kinase enzymes M and B. Both troponin I and T levels can be elevated in the blood within 2 to 4 hours after infarction, and usually peak around 48 hours, but stay elevated for 7 to 10 days. CKMB starts to rise 2 to 4 hours after infarction, peaks around 24 hours, and returns to normal after 48 hours. Since CKMB returns to normal more quickly, it can be useful to diagnose reinfarction, a second infarction that happens after 48 hours, but before troponin levels go back to normal. A second heart attack happens following 10% of MIs. A major complication with MIs are arrhythmias, or abnormal heart rhythms, with the highest risk being immediately following an MI, since the damage or injury can disrupt how the cells conduct electrical signals. Kind of along the same lines, depending on how much contractile or muscle tissue is affected, patients' hearts might not be able to pump enough blood to the body, resulting in cardiogenic shock. In the days following an infarction, the tissue around the infarcted area becomes inflamed and is invaded by neutrophils, which can lead to pericarditis, inflammation of the pericardium. In the next couple weeks, macrophages invade the tissue, and the healing process begins with the formation of granulation tissue, which is new connective tissue that's yellow and soft. At this phase, the tissue is most at risk of myocardial rupture. After 2 weeks to several months, the cardiac tissue scarring process finishes, and the resulting tissue becomes grayish-white in color. Since the scar tissue doesn't help pump blood, over time the remaining heart muscle can grow or change shape to try and compensate for these lost cells and pump harder. But they ultimately continue to fail, which can lead to heart failure. Now, a potentially life-saving treatment that can be done immediately following an MI is fibrinolytic therapy, which uses medications to break down fibrin in blood clots.
Okay, so we're not going to talk about the therapy and the treatment portion. So skipping ahead a few slides, because all the information is everything that you needed to receive for the acute coronary syndrome and MI portion. pain was covered. Looking at this slide here so that you can understand what is going on. In a person that has signs and symptoms, they have the chest pain, they have all the signs of unstable angina. We do an EKG on this patient, and there's absolutely no changes on the EKG. And when they do blood work on this patient, there's no serum markers indicating elevated troponins or CK or CKMBs. In this situation, we consider that unstable angina. There's no infarction at this time, possibly some ischemia, but no infarction. The difference is that in somebody with that is having all the manifestations of unstable angina, again, they may not have any EKG changes, so there may not be any ST changes or elevation on the EKG. But when we draw their blood work, we see clearly elevated troponin levels or CKMB levels, and that would be considered a non-STEMI or a non-ST segment elevated MI. The video covered a lot of this. I'm not going to go over this again. This is a picture of kind of what it was talking about over the time frame of what happens. What you see is that yellow formation here, and it's going to eventually be scar tissue. And your book talks about this being a transmural infarction, and so all of this stuff that is yellow is dead cardiac tissue and will not function properly. So let's talk a little bit about chronic ischemic heart disease. So basically with chronic ischemic heart disease, you have ischemia in the heart tissue where there's an inability of the arteries to supply enough blood and oxygen to meet the demands of the heart. So we have less blood flowing to the heart, but we have higher oxygen demands. Unless the blood can actually get to the area that's ischemic, you're not gonna have relief of that ischemic in that area. So chronic heart disease is divided into 3 classifications. Stable angina is the one that we are going to focus on. So you have chronic stable angina. You need to understand that chronic stable angina is a symptomatic chest pain or pressure that results from transient ischemia. So kind of like a sudden onset of ischemia. Due to a fixed obstruction or of blood flow. So basically it's stable angina. So I want you to think of this as being predictable. These people have angina with exertion. They generally will have chest pain. And they're walking to the mailbox and they know they can't go 300 feet. And generally they'll have chest pain at that point. If they stop and sit down and rest, then the chest pain usually subsides. And with stable angina, it's generally easily taken care of if they give a nitroglycerin to the patient. So any situation that increases the oxygen demands of the heart, running, walking, exertion, activity, cold weather where your body's trying to get warmer by shivering and increasing metabolic rate, any of those things can kind of precipitate this angina. Cold, so I said activity, cold, stress, anxiety, things like that. Generally, the pain is typically a constant squeezing pain. It feels like they're suffocating. It's similar to the pain that we just discussed. However, and it can still radiate to the jaw and the arm and be confused with indigestion. All of those same signs and symptoms that you saw are signs of chronic stable angina. The difference is that with chronic stable angina, this pain will usually subside when they sit down and rest or decrease their oxygen demand to the heart. So providing oxygen to a patient with chronic stable angina usually is very beneficial and can eliminate the chest pain altogether. Basically, the only thing we do definitively that we can diagnose because there's no changes in the EKG and there's no enzymes or markers that are elevated. So there's nothing visually to tell us that what's going on. So they'll do a coronary angiogram or a heart cath on the patient so they can visualize the coronary arteries and they can see if there's any or how bad the atherosclerosis in the narrow and the artery is. This picture just shows you an example of the areas of of angina, and the video covered it pretty well. I'm gonna end the video here.